So, as sir has already told you that today we will present our experience with COVID-19. So, the title is COVID-19 from 7 to 7 lakhs. Experience from a microbiology lab, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And so, because when we started way back in March, late March 2020, then we started with a very few tests. Initially, we used to get seven. We started with 7, then 8, then it kept on increasing, and it all started on March 19, 2020, when ICMR chose us, our laboratory, among few other centers, to perform RT-PCR for COVID-19. Naturally, the pandemic was new. Nobody was prepared, and so were we. We did not have any space extra because it is very infectious. You need to do in a separate place. So we did not have any space. We did not have dedicated equipment for this and very little manpower. So in just 3 days, a very small lab which was dedicated for this COVID-19 patients. And initially only for the patient who were attending SGPGI, it was established. Actually, we were fortunate that a new diagnostic block was coming up, but there was no water supply, there was no AC, and it was not still was handed over to us. And there was a wall, there was a cement wall between the old block where we work, where the old virology block is, virology department is, and among this new diagnostic block. So overnight, this wall, in 2-3 days, this wall was broken. All the facility was provided. Our administration was proactive, and that is how the lab started. Then we received help from other departments also, and instruments also, in terms of manpower also. Everybody helped, and then we started receiving samples from other districts, and from a patient also started increasing. And so far we have tested samples from more than 25 districts of UP. So left side, you can see how this side, this was old block, and across the wall was the new block. Then this was broken. So you see the next picture, and these were the status of the lab. And now, after all this is how our lab looks like now. So it is a lab. And now, can you hear? Please mute yourself. Mute. So this is how our lab looks like. It is how it looks like now. So now it is, over the period of time, it has established very well. So since past, earlier we used to work from most of the people from lab used to run from 9:30 till 5, and then we had the academic session from 8, so 8 to 5. Now, since past 8 months, the lab is catering to the needs 24/7. It has not closed down for a single day. Primarily, we are doing 2 tests. One is real-time PCR, which is the gold standard, as you all know. And then we are also doing indigenous rapid microchip-based PCR testing, rapid testing, that is TRUENAT. I'm sure you all are aware. So usually we do, depending upon the sample we get, usually it varies from 5,000 to 6,000 or so per day. But in a single day, we have done maximum up to 7,748 sample in a day, and which is to the best of our knowledge, it highest from a single center in India. And till now we have processed, this is a bit old data, till now we have processed around close to 7 lakh samples as far as RT-PCR is concerned. So these are few more pictures from our labs. Then apart from the testing, we also, because for testing it is very important that you have to have a good sample. So for that, we have opened a few sample collection centers also. So the first center was opened on 23rd March. we have a SBI counter here inside in our main building. So there the first center was opened. Then gradually, as the need increased, two more collection center came up, one near the old center and one near the Rajdhani COVID hospital. So we collect samples also, and apart from that, we conduct training session for healthcare workers about for sample collection, doffing of PPE, infection control, biomedical waste management, and others. Then doctors and technical staff from various other institutes were also trained for RNA extraction, handling automated extractor, RT-PCR, how to report, how to interpret, and how to manage this huge data. This is showing you the few picture of this training session. So in this today's CGR, 4 of us will be presenting, and it will be presented like one in different session, 4 different session. First, clinical interpretation of RT-PCR reports. How do you interpret? Repeat testing. Sometimes we give report like repeat testing in RT-PCR COVID-19 patients. So when you get repeat testing or kindly repeat, what does it mean? Why it is so? Then third, whatever data we have so far, that will be briefly presented to you. And finally, apart from the testing, we are also involved in research. So ongoing research projects and upcoming projects in the department will also be discussed. So now I invite our senior research associate, Dr. Nidhi Tejan, to tell you about the clinical interpretation of COVID-19 laboratory reports. Dr. Nidhi, please.
Good morning, all. As ma'am has already told you, I'll be presenting the part on clinical interpretation of COVID-19 laboratory reports. So in our lab, we are conducting 2 tests. One is RT-PCR, that is reverse transcriptase PCR, and other one is TRUENAT. Both are the molecular tests and detect the nucleic acid of the virus. So for these, we collect samples, mainly the oropharyngeal and nasopharyngeal samples. For RT-PCR, we are getting both the samples, and for TRUENAT, we are getting only the oropharyngeal samples. And both the samples are transported in special transport media. One is viral lysis media, the white one, the white vial you can see. It is viral lysis media, and this is required for TRUENAT sample transport. The composition is a patented product of the Mole Biodiagnostics, and the advantage of this viral lysis media is that it can be kept at room temperature for 3 days. So storage requirement is storage does not need refrigerated conditions. And the other one is the viral transport media, which is the commonly used VTM. The composition is balanced salt solution, and the storage is done at 2 to 8 degrees Celsius for 1 week. So we have 2 types of swabs. One is the thicker one. We require 2 types of swabs. One is a thicker one, and other one is the thinner one. The thicker one is required for oropharyngeal sampling, and the thinner one is required for nasopharyngeal sampling. Both the swab sticks have grooves inside, grooves on them, so that we can break them and put inside the vial containing the transport medium. Because we required, it is needed that we break the swab stick so as to ensure that the lid of the vial is closed properly and there is no leakage of the sample, and hence the sample is not rejected. So coming to the PCR, we target certain regions of the genome of the virus. As you can see, the 2/3 of the genome on the right side, on the left side is occupied by the ORF region, that is open reading frames, which are the regions used for confirmation of the test. While on the left side, on the right side, there are structural genes, that is SG, E, M, and N, which are used for screening purposes, and these are present all the beta coronaviruses. So first step is screening assay, and then we confirm the results of the screening assay. So initially it was as per the ICMR protocol, we used the screening genes from outer structural region, and then we use the confirmatory genes from the conserved region. But the estimated time for this cycle was around 10 to 12 hours. So currently, we have started multiplex real-time RT-PCR, where both the screening and confirmatory tests are done at the same time, and it saves around 3 to 4 hours. in the picture, you can see an amplification plot where all the genes are have crossed the threshold and are seen, and we can see that they are amplified, and the positive results are shown by the sigmoid curves in the amplification plots. So, what kind of reports do we get? Either we can get a positive report, we can get a negative report. So, or we can give a report like, please repeat the sample. Please repeat, kindly send a repeat sample. Somebody has done this.
It doesn't matter. Go ahead.
True positive means it detects the presence of SARS CoV-2 RNA. The source of the RNA could be from a live virus, which has invaded the respiratory epithelium and is causing the disease. And it can be from a dead virus or a fragment of virus, which is present as a remnant RNA from the human cells and is being detected in the PCR. It's getting amplified. And then we have, we can get false positive results also, which may occur due to cross-contamination during specimen handling or preparation, or RNA contamination during product handling, or there may be wrong labeling at the time of sample collection. Then we can get negative results. Either they can be true negative or they can be false negative results. True negative means there is absence of RNA in the sample received, while the false negative results may arise from, again, improper sample collection, then degradation of the RNA during shipping or storage, and there may be presence of certain inhibitors of the PCR in the samples. So in this slide, you can see the 4 different amplification plots, which are showing different interpretation of the PCR. In the picture A, you can see that the internal control has been amplified, while no screening or confirmatory gene is amplified. So there, only one sigmoid curve is showing it here, and it is the RNase P gene. Then in the picture B, there is no internal control. Even RNase P gene is not getting amplified. That means the sample has not been collected properly. Then in the plot C, we can see that this is a positive sample with all the 3 genes being amplified. In the picture D, as you can see in the amplification plot, RNase P gene is getting amplified, the blue one, and there is another gene which is getting amplified. This is, I guess, E gene. Yes, this is E gene that corresponds to the envelope gene. So in these cases, where only one gene has been amplified, we ask for a repeat sample, because this may be due to either the dead virus which is getting amplified from the sample, and a patient may not be infectious anymore. So again, we have another test which is called as TRUENAT test. It is a chip-based RT-PCR test based on Tachman chemistry for the semi-quantitative detection of beta coronaviruses. And the sample we are getting for this is oropharyngeal swabs. The targets are RNase P gene, which is internal PCR control, and E gene and RT-RP gene. Then the limit of detection is 486 copies per ml. And again, the media used is viral lysis media, as I have told earlier. So the TRUENAT test has an advantage that the turnaround time is around 2 hours after receiving the sample in the lab. And according to the old criteria, till 23rd October 2020, the CT value less than equal to 35 was considered as positive. But according to new criteria, after 23rd October 2020, E gene or the RT-RP CT value should be less than or equal to 32. Then only the sample will be considered as positive. So the lab provides the simple positive or negative reports for this test. So I would now like to invite Dr. Atul sir to tell you about the nuances of repeat testing in a confirmed COVID-19 patient. Thank you.
Good morning, everyone. I'll be discussing about the repeat testing or retesting in a COVID-19 positive patients. Now, these are the national discharge policies. This is from the Ministry of Health and Family Welfare. Now, the patients are divided into 3 categories: mild, moderate, and severe. For mild as well as moderate category, the guidelines say that there is no requirement for RT-PCR testing before the discharge. The patient is discharged with the advice of home quarantine for 7 days. So 10 days of hospital stay plus 7 days of home stay, and after 17 days, the patient is allowed to rejoin the duties without any retesting. However, for severe patients or the patients who are immunocompromised or HIV or transplant recipients, they should have at least one RT-PCR negative reports, then only they are discharged from the hospital. So in continuation to these national guidelines, SGPGIMS academic committee has formulated these guidelines that here we discharge the patient once a patient is RT-PCR negative for mild, moderate and severe category. In SGPGIMS, we have two hospitals. One is Rajdhani Corona Hospital, which caters only to COVID patients, and second is the old SGPGIMS, which is a non-COVID hospital and providing other super specialty facility. So if there is a COVID patient who require a super specialty treatment in non-COVID areas, then the patient should have two negative RT-PCR reports. Once the patient has two negative RT-PCR reports, the patient is shifted from COVID hospital to non-COVID SGPGIMS areas, and the patient is giving a further super specialty care. Now, what are the testing guidelines of COVID patients who are transferred to a non-COVID area? This happens like in PGI, we have two hospitals. In most of the cities, presently there are two hospitals, a COVID hospital and a non-COVID hospital. A COVID patient after a RT-PCR negative report is shifted to a non-COVID hospital for further treatment and management. At the time of treatment, frequently the RT-PCR samples are sent before any procedures, before scopies, before doing investigations, radiological investigations, and sometimes these patients turn out to be positive. The patient although healed and well, but they turn out to be RT-PCR positive. This is a publication by Meena et al. From New England Journal of Medicine, in which they have told that for the first 8 days, the patient is antigen positive. By 15 days, the patients become RT-PCR negative. And in minority of patients, the patient can be RT-PCR positive for a very long time. In fact, in literature, it has been reported that patient can be RT-PCR positive for as long as 90 days. So, are these patients infectious? That if you are RT-PCR for 40 days or 50 days? No. As per the CDC data, this is an excellent publication from CDC. Using Kaplan-Meier analysis, they have shown that by day 4, the live virus is reduced to 50%. By day 8, the virus load is reduced to 80%. And almost at 100% of the patient, no live virus or no replicating virus could be cultured or isolated from the patient. So practically patient is non-infectious after day 10. So based on these data, CDC has come up with the guidelines. They say that for mild to moderate severity of COVID-19 patients, a replication competent virus or live virus have not been recovered after 10 days following onset of symptom. In immunocompromised patients or patients with severe disease, the live virus cannot be isolated after 20 days. So based on these data, the CDC has come up with the guidelines that among asymptomatic patients after recovery, retesting is not recommended within 3 months. Thus, if you have a COVID positive patient who 10 to 15 days have passed, the patient has become RT-PCR negative and is in a non-COVID area or non-COVID part of your hospital, then don't retest the patients, because the patient might turn out to be positive, but the positive is because of the sensitive nature of RT-PCR test. As in the earlier slide it has been discussed, the positivity can be because of the fragment of virus or fragment of RNA present, but this virus is not infectious or non-replicating. In this regard, there is a recent publication in JAMA. In this study, 176 COVID positive patients were enrolled and RT-PCR was done for a long period of time. There was two types of RT-PCR. One was the genomic RT-PCR for detection of SARS coronavirus 2, and second was a replicative subgenomic PCR. Replicative subgenomic PCR suggests a live virus. So the live virus could be found only in one patient. That is, of the 176 patients, only one patient have live virus. So practically, if this patient was immunocompromised and on chemotherapy. The second part is CT values. We get a lot of calls from our clinician colleagues to tell the CT value of the patient, because theoretically, the higher the viral load in a sample, lower is the CT value. this is but theoretical only, because as per the theory, in the initial days of the disease, the CT value is very low, 14, 15. Then by day 4, it increases to 26. By day 8, it crosses 30. And after day 10, it crosses 35, and generally patient is negative. But practically, we don't see such good curves, because the most important factor is the quality of sample. If a good nasopharyngeal swab is collected, then the CT values are generally low. So for the viral loads, actually in a CT value, it is mainly the quality of the sample which is most important factor as compared to other factors. Apart from the sample, CT values differ from one kit to another. CT value depends on the technical expertise of the person, and the most important part is the viral loads have no role in the management of the patient. The pathogenesis of disease is because of immunological mechanism, cytokine activation, so many factors that it is not directly related to a viral loads. So in this view, it is not recommended to rely on the CT values for determining infectiousness of a patient and on the deciding of patient protocols and management. With this, I'll finish my presentation. Thank you, and I'll invite the next speaker, Dr. Nidhi Bhattacharya. She is a senior resident in our department, and she'll be discussing the SGPGIMS as well as national and state-based data of COVID-19.
A very good morning to all of you. I will be discussing briefly about the SGPGIMS experience of COVID-19 molecular testing. So, as we all know that India has crossed a significant landmark in testing for COVID-19, and more than 15 crore tests have been conducted so far for COVID-19. And UP is at the #1 level regarding the testing for COVID-19, where alone more than 2 crore tests have been conducted so far. So this is the data of SGPGIMS, where we have conducted around 6.5 lakhs. This is the old data. Now it is around 7 lakhs. And we are here testing not alone the samples from SGPGIMS. We are also catering to the around 24 to 25 districts. And this is a dynamic process. So around at a time 6 to 7 districts are being allotted to us, and we are testing samples from those districts also. So currently these are the districts from which we are getting the samples, and till now the positivity rate, overall positivity rate, what we have seen is around 2.7%. From starting from 23rd March, when we have started the testing for COVID-19. So this is the month-wise data. In the first month of April, when we started testing, we received around 6,796 samples. So what we tested at that time in a single month, now this much of the samples we are testing in a single day. And in the first month, the positivity rate, what we saw was around 2.1%, which slightly increased to 3.1% in the month of May. And the number of samples which we were receiving also increased up to 40,000 in June, and the positivity rate was 2.6%. But the maximum positivity was seen in the month of July, when the lockdown was lifted off, which is around 4.2%. Similar positivity rates were also observed in August and September of around 4% and 3.3% respectively. From October onwards, there is a declining trend, and the number of positive samples has reduced significantly. The positivity rate in October was around 1.8%, and in November it was around 1.3%. So this is the positivity rate. The maximum positivity was seen in the months of July, August, and September, and from there onwards we are seeing a declining trend. So these are the number of samples being tested. In UP, around 2 crore tests have been conducted so far, out of which 1 crore is done by antigen testing, and 1 crore is done by molecular testing, out of which 20 lakhs have been tested by TRUENAT and around 80 lakhs by RT-PCR. Out of these 80 lakh tests, SGPGI alone has tested around 6.5 lakhs. And the overall positivity seen was 2.67%. but the samples which have been received from SGPGIMS alone is around 89,000, and the positivity rate is also higher as compared to the overall positivity, which is around 7.3%. And the most important factors for this increased positivity is because of better sample collection techniques that we are following in our institute, and also the transportation time of the samples is very less, and we are maintaining proper cold chain while the transportation of those samples to our lab. And the most important factor is since we are at the tertiary care level, we are receiving samples from mostly symptomatic patients, and which are more severe patients are being referred to our institute. Thank you. Now I would like to request Professor Ujjwala Ghoshal ma'am to talk about the research on COVID-19 in our department.
Thank you, Dr. Nidhi. Since research is an integral part of our activity, so in spite of our busy schedule, we try to do some research on COVID-19. So far, I'll give you a glimpse of that. So far, we have published around 6 papers on COVID-19. 3 are in pipeline. We have submitted an extramural projects. We are also the co-investigator of 3 extramural projects which have already come. Then we also do have an intramural research project on COVID-19. Then this is showing you the list of the published articles which have already been published. How much time do I have?
30 minutes.
30 minutes. Okay.
No, it's 20 minutes.
Okay, it's okay. So these are the 6 papers, list of 6 or 7 papers which we have already published, and you can see here the impact in various impact factors from 1 to 1, 2, 3, and up to 5.5, which is the highest so far what we have published. Then these are in the pipeline. Now I will discuss this very briefly one by one. So the first paper, which was published in a very high impact factor journal, that is the Clinical and Translational Gastroenterology with an impact factor of 5.5. The topic is the spectrum of GI symptoms, gastrointestinal symptoms in patient with coronavirus disease 19, predictors, relationship with disease severity and outcome. So here we included around 16,317 patients from 23rd March till 17th May 2020, and out from various, as you can see in the picture, that these were mainly from UP and from various districts, as you can see in the map, that from various districts of UP, which have been depicted in the picture. Of these, 252 were positive, and of these 252, around 82.5% were asymptomatic, and rest were symptomatic. These were categorized into mild to moderate, then severe and critical. And of these 44 symptomatic patients, 41% patient had non-GI symptoms too, whereas around 25 patients, they had only GI symptoms. Normally we think of coronavirus disease when there is respiratory symptoms, fever and others, but here what has been shown that in absence of the respiratory symptoms also, there may be coronavirus disease. As this pictures depict the same, that among 16,000 patients, 252 were positive. Among positive, 208 asymptomatic, 44 symptomatic. And among these, 41% patient had non-GI symptoms, both non-GI and GI symptoms in 34%, and in 25% patient only GI symptoms like nausea, vomiting, abdominal pain, diarrhea, anosmia, etc. So univariate and multivariate analysis was done to see what are the various cofactors or various risk factors. So it was found on multivariate analysis that the factors associated with the presence of GI symptoms were absence of contact history, presence of a non-GI symptom, and associated comorbid illness. Also, the presence of GI symptoms was a marker of more severe disease and fatal outcome. Now, this is the second paper which we published in Journal of Medical Virology, and it is regarding the evaluation of 7 commercial RT-PCR kits for COVID-19 testing in pooled clinical specimen. As we all know that the RT-PCR is a gold standard, and in market around more than 350 RT-PCR kits are available. So the aim of this study, since most of these have been tested in not in pool sample but in single sample, but now we are supposed to do pool samples because we have to test large number of samples. So as per government directives, we are using pool of 5. So the aim was to compare and evaluate 7 commercially available test kits for pooled sample testing, because these have not been evaluated in pool sample but in individual samples. So we used 7 case samples, 7 kits, and all 7 kits detected. I will tell you very briefly the results, that all 7 kits detected all strong positive cases which had a CT value less than 30. But then we get many cases when the CT value is more than that. What about that? So while testing weak positive pool sample, which have a very high CT value that is more than 30, only 4 kits showed 100% sensitivity, specificity, and accuracy. So if the results shows that if you have a patient which has a higher CT value, more than 30, then you can use only these 4 kits. And the other kits, if you use other kits other than these 4 kits, the rest of the 3 kits will miss those cases. So that was the message. Then we also wrote a review in pathogens, which has an impact factor of more than 3, regarding along with our collaborators from India and abroad. It is coronavirus disease pandemic, COVID-19 challenges and global perspective. It was written around 6 months back, and this when we knew very little about the disease. And this review focused on SARS CoV-2 viral agent, comprehensive genome analysis, population susceptibility, disease epidemiology and diagnosis, animal reservoir and lab animal models. What are various lab animal models for this? Disease, how the disease is transmitted, various therapeutics, and what about the challenges as far as the vaccine is concerned. So all these were discussed in this review. Then another is on gastrointestinal and hepatic involvement in severe acute respiratory SARS-CoV-2. Here also, this review emphasized that GI symptoms such as anorexia, nausea, vomiting, loss of taste sensation, diarrhea, abdominal pain, and discomfort may be present, or these may be the presenting symptom in COVID-19. The pooled prevalence of GI symptoms is around 7.6%. And few studies, as I showed you the one from the US, which was one of the few initial studies, it suggested that the GI symptoms, that if the patient has GI symptoms, it may have poor prognosis. Then another paper, this is a guide, a lab guide to the laboratory diagnosis of COVID-19 for the gastroenterologist, as it has GI symptoms also. Therefore, the knowledge about the diagnosis of the COVID-19 is important to the gastroenterologist as well. So this review covered the challenges faced while choosing an appropriate sample for COVID-19 detection, and also emphasized that the right sample at the right time from the right anatomical site with the proper precaution is crucial in prompt and accurate diagnosis. Then this is another paper where it was shown that there's a lack of specificity. Since we don't have drugs, vaccines are still in the pipeline. So the rapid diagnosis and management are very crucial for controlling the outbreak, because if you miss a case, it will spread the disease in the community. So that's why there's a need for the development of a rapid test. So here in this test, a rapid colorimetric assay, which is capable of detecting SARS-CoV-2 in human nasopharyngeal RNA in less than 30 minutes, was developed. So here, a nanoparticle-based optical sensing platform were utilized to detect RNA RDRP gene or SARS-CoV-2, and it has it could be used for the rapid diagnosis. Then these were the submitted papers which have already been published. Now the few papers which are in pipeline, and one of them is evaluation of the TRUENAT for the and also antigen detection test for the diagnosis of SARS CoV-2. So as we all know that though the RT-PCR is gold standard, it takes time, and also it is costly, and its turnaround time is long, 10 to 12 hours, and it needs huge infrastructure. That is, you have to have a proper lab, you have to have trained technician, you have to have RT-PCR machine and biosafety cabinets and whatnot. So, and which is not possible in remote areas. So, a rapid, simple, cheap diagnostic test with a high sensitivity and specificity was introduced by an indigenous company, that is a company from the Goa, which is known as MOL Bio, MOL for molecular. So, MOL Bio Diagnostic Private Limited, and it is called TRUENAT. This test was available earlier for the diagnosis of TB, but now they have modified it for many other diseases and for the diagnosis of SARS CoV-2 also. So it is a portable device. Results are available within 1 to 2 hours, and it may be used as point of care test. That is near the patient. You take sample, dip it in viral lysis media as discussed earlier, and since a machine is very small, so you don't need to go to the lab. It can be done at the bedside near the patient only. And also it uses, since as I told, it uses viral lysis media, where when you put the sample, virus get inactivated. So chances of infection during the transportation or processing of samples, which are there with the RT-PCR, they are also less as compared to the RT-PCR. Then something regarding this evaluation, what we, in our experience, we studied around, when this data was analyzed, around 4,592 TrueNat tests were carried out in span of 4 months from June to October, and around 1,400 samples were tested by both TrueNat and RT-PCR. So these were compared, and we found that the sensitivity is around 81%, specificity 85%, and accuracy around 85% again. So this shows that in cases where there is emergency, where there is no facility for the RT-PCR, and when even in the facility is there, but patient doesn't have that much time, the diagnosis is urgently required, like in case of MI, or in case of labor, or any other acute emergency surgeries, there it can very well be used for the diagnosis, right? Then another point of care test, you all know, antigen detection test, that we also analyzed, that is also used especially in the peripheries where there are no labs, and even POCT is not there, or even at the airports where migrants are coming, or before the patients are, or the people are allowed to enter. So another point of care test has been introduced by SD biosensor for the rapid diagnosis of SARS CoV-2, which does not need huge infrastructure and technical expertise. It has high specificity, but its sensitivity is a problem. It has a low to moderate sensitivity, and it can only be done during the first 6 days, right? Because after first 6 days, antibodies start rising, and then it is not possible. So in a small subset of 230 individuals, in which RT-PCR and TrueNat was also done, this antigen testing was done. And if we look, the sensitivity was around 47%. The specificity was very high, close to 100%, and positive predictive value and negative predictive value and accuracy were also very good. So if it is a positive, antigen is positive, it is positive. But if it is a negative, because owing to slow sensitivity, that means it is going to miss around 53% cases. So if it is negative, then it has to be confirmed by RT-PCR. Then another paper is on bacterial co-infection COVID-19, prevalence, antibiotic sensitivity pattern, and clinical outcome from a tertiary center of northern India. I will briefly, so here, as we know that the bacterial co-infection are important leading cause of mortality and morbidity during COVID-19. And systematic testing of COVID-19 patient with bacterial co-infection is very essential in order to choose the appropriate antibiotic for proper treatment, and so as to increase the chance of survival and also prevent the spread of antimicrobial resistance. So the aim of this study was to study the prevalence, demographic parameters, risk factors, antibiotic sensitivity pattern, and outcomes in hospitalized COVID-19 patient with bacterial co-infection. Now the results, of 1000 total 1019 COVID-19 patients and screened, and around 5.2% demonstrated clinical signs of bacterial co-infection, bacteremia, respiratory and urinary tract infection. Bacteria was most common, followed by respiratory and urinary tract infection. And as far the organisms are concerned, E. coli was most common, followed by Pseudomonas, then Klebsiella, in that order among the gram negatives. Among gram positives, coagulase negative species and Staphylococcus aureus were the most common organism in gram positives. Regarding the antibiotic profiling, colistin, and imipenem, and phosphomycin, they were the top 3 most effective drugs, whereas the vancomycin and teicoplanin were most effective against the most potent against the gram positive bacteria. Then, so this was something about the papers. Now the projects, one extramural projects we have already submitted. We are also doing 3 projects as a co-investigator from the Department of Biotechnology, Department of Science and Technology, and ICMR. And also we have a one intramural project for the detection of, and the title is Detection of Inflammatory Biomarker in Gut and Inflammatory Response in Serum in Patient in COVID-19. So I would take this opportunity to thank ICMR, Government of India, and NIV Pune for their support, and also Department of Medical Education and Health, Government of UP, which are providing us all the support, logistic support, RNA kits, PCR kits, and also the guidance from time to time. Then our local administration, which is proactive and very helpful. And I will also like to thank all those who are working very hard and are involved with diagnosis and care of COVID-19 patients and are involved in research with us. And a big salute to all corona warriors who are working 24/7 since last 8 days. And today what we are largely because of contribution. Thank you very much. And these are a team of corona warriors who are working very hard and doing this job. Thank you very much.